Hello and welcome to the topic Upper Gastrointestinal Bleeding in the module Gastroenterology and Hepatology. By the end of this topic, you should be able to define upper gastrointestinal bleeding, discuss the pathophysiology of upper gastrointestinal bleeding, explain the clinical presentation of a patient who presents with upper gastrointestinal bleeding, outline the investigations in the diagnosis of upper gastrointestinal bleeding, and finally, discuss the principles of management of upper gastrointestinal bleeding. Let's get started. Upper gastrointestinal bleeding is bleeding from the upper gastrointestinal tract, commonly defined as bleeding arising from the esophagus, stomach, or the duodenum. Blood may be observed in the vomitus or in altered form as black stool. Depending on the amount of the blood loss, symptoms may include shock. If we're looking at the risk factors, you may want to consider old age as a risk factor, any past medical history of prior GI bleeds or having GI ulcers, diverticulitis, history of Helicobacter pylori infection, as well as inflammatory bowel disease may pose as risk factors as well. Medication intake such as drug, primarily NSAIDs, anticoagulants and antiplatelets may pose as a risk for upper gastrointestinal bleeding. And last but not least, a social history of consumption of alcohol as well as tobacco smoking may need to be elicited as well. So here seems to be a disruption of the mucosa barrier added on to the inflammation of the stomach and the duodenum, which then leads to ulcers developing and progressing beyond the mucosa to the submucosal layer. This causes inflammation and then consequently causing weakening of the arterial wall. This then leads to a formation of a pseudoaneurysm, which then eventually would rupture or bleed, and this leads to GI bleeding. Symptoms of gastrointestinal bleed may include bright red blood in the vomitus, black or tarry stool, which is known as melanic stool, patients having dizziness or faintness, feeling tired, pale, shortness of breath. Now these are all signs of anemia. Vomit that looks like coffee ground, and we call it coffee ground emesis, as well as dark bright red blood mixed with stool. In terms of signs, don't miss out signs of shock, such as hypotension, tachycardia, oliguria, or anuria. Additional signs you may want to look out for is bleeding from the mouth or anus that can't be stopped, fever or anything higher than 37.8 degrees, bleeding accompanied by lightheadedness or dizziness, as well as signs of dehydration, someone having dry, sticky mouth, decreased urine output, and very dark urine. In terms of lab investigations, consider doing a full blood count to look at the hemoglobin levels, urea and electrolytes to look at the degree of dehydration. Cross-matching can be done instantly to prepare for blood transfusion. Liver function test and coagulation profile to ensure there's no ongoing bleeding diathesis, a basic metabolic panel, fecal occult blood test, as well as a blood urea nitrogen to creatinine ratio. Now, other investigations that also can be done and may be useful would include stool tests, urine tests, anything testing the vomitus, as well as nasogastric lavage. Imaging studies and scopes that can be carried out include X-rays of the abdomen to ensure there is no perforation, Doppler ultrasonography, and CT scan, which may be used depending on the suspected underlying medical problem associated with the internal bleeding. CT scans is a primary tool used in emergency situations to access for the site of bleeding. Other than that, you may want to consider more diagnostic tests such as an upper endoscopy. So this diagnostic test of choice is done for acute hematemesis due to the high sensitivity in the ability to locate and treat specific locations of active bleeding lesions. Therapeutic endoscopy can be performed with esophageal variceal bleed banding, clips, sclerosing agents, epinephrine injection, and thermocoagulation. In most circumstances, the standard of care for the initial diagnostic evaluation of suspected acute upper gastrointestinal bleeding would be an urgent upper endoscopy or colonoscopy as recommended by guidelines. Vasoconstrictor therapy is given to reduce splanchnic flow, An example of a medication that can be given would be telepressin. It's the only agent which has shown to improve control of bleeding and survival. Other than that, you may also consider octreotide, which is known as a somatostatin. Antibiotics can be given prophylactically, which reduces incidence of bacterial infection, significantly reduces early rebleeding. And finally, resuscitation is done promptly with caution to maintain hemodynamic stability. Enteroscopy is considered if bleeding site is in the proximal jejunum. This is used with a device-assisted deep enteroscopy. You may also consider angiography and embolization if the bleeding can be stopped, and intraoperative enteroscopy. To summarize, we have understood what is upper gastrointestinal bleeding, where does the bleeding come from, what are the potential risk factors and causes to upper gastrointestinal bleeding, how does the patient present with upper gastrointestinal bleeding, important investigations to help you diagnose and also assess the severity, which may also play a role as therapeutic interventions, and finally, medical and surgical therapy that are warranted in acute upper gastrointestinal bleeding. We have come to the end of this topic. Thank you.